Welcome back to this class on Ultra Rapid Revision of Surgery Part 6. My name is Dr. Jhanvi and today we are going to be continuing with our series that we have started this month, in which we will be discussing the entire surgery over a series of 10 to 12 lectures. So for all of you who are new to this series, I would like to tell you that we have already completed Ultra Rapid Revision of esophagus. Small intestine, half of it was completed, half is remaining, which we'll do today. Then we have done swellings in surgery, and we have done head, face and neck, and we have done the whole of stomach. Okay, so today's class we are going to be covering the remaining part of small intestine. We are going to be doing appendix and intestinal obstruction. Now these three are the most important topics in GIT that will come. Tomorrow's class we'll be doing large intestine, and then day after tomorrow's class we will be moving on to urology or GU, genitourinary system. All right, so let's begin with our class for today. First of all, I hope that all of you all are able to see me and hear me well. If the streaming is absolutely fine, please leave a thumbs up in the chat box. Yeah, okay, great. I can see that you all are able to see me and hear me well. So this is the Telegram channel Let's Crack NEET PG, which will have the links to all our free lectures, and also the schedule of all the links will be posted over here. And these are our FMG December 2021 toppers. The plus subscription on Unacademy will help you get access to live and recorded classes. You can learn from India's top educators, and you can also compete in live tests and quizzes. Along with that, you can study from the safety of your home during the time of this pandemic. The iconic subscription is a partnership between Unacademy and PrepLadder, which will help you get the live lectures of Unacademy along with the recorded video lectures of PrepLadder. Now on the 23rd, we have the NEET PG Combat, which this time has short subjects and medicine. There are prizes worth 10 lakh rupees and free Unacademy Plus subscriptions to be won. So make sure at 11 AM on 23rd Jan you do attend Combat. Our special classes are available free for y'all. You all can watch it and download the lecture notes at the end of it. And you can also use our question bank, which has 25,000 plus high yield questions. We have raise a hand option in our classes, in which you can speak to the educator live on the Unacademy platform. And these are a few of the batches that are going on currently. So we have the Target NEET PG 2022 and the Focus FMG 2022 batch. These are our free test calendars, and you can see that there are tests on ENT, Ophthal and pathology that are coming up on 17th, 22nd and 28th of Jan. They are absolutely free, and you can also win prizes on acing these tests. This is an integrated batch that we have, which will have integration between different subjects, and this is our NEET PG plus subscription pricing plan. So you can see that it's a very cost effective plan, and if you would like to try the Unacademy Plus subscription, on top of that plan you can get an extra 10% off on your subscription if you use my code Dr. Jhanvi Life. All right, so with that, let's begin with our class for today. This is the first question that I have for you guys. A 3-month-old child is brought through the casualty with vomiting, dehydration and drowsiness. This is the abdominal X-ray of the child. Identify the disease. Meckel's diverticulum, duodenal atresia, CHPSS or Meconium Ileus. Yes, in fact, just like 15 seconds ago, we have uploaded a video on 3 effective revision strategies for NEET PG exam, and I will send the link of that on the Telegram group for you guys, so that you all can use it for it's just a 3-minute video which will give you 3 effective revision strategies. Okay, great. So all of you have answered it correctly, and you all have said it is duodenal atresia. Now you don't even need to look at the question for this. You don't need to see the clinical features or anything. You just have to look at the radiological image that is given, and what can you see over here? You can see 2 bubbles. One bubble is of the stomach and one bubble is of the duodenal cap, correct? So this is called as double bubble sign. And where do you see double bubble sign? Double bubble sign is seen in duodenal atresia. Okay, now let's discuss about duodenal atresia. So initially we'll start off with all the causes of intestinal obstruction. Okay, so what happens in duodenal atresia? I will ask you the question, you have to tell me the answer, and these are direct one-liners that come in the exam. Okay, so first question that they ask is, what is the site of stenosis in duodenal atresia? Obviously, you know it is in the duodenum, but which part of the duodenum is the one that has become atretic? Okay. Then second question that they ask is, it is due to defective fusion of which two parts of the gut? Is it foregut, midgut? Is it midgut, hindgut? Is it foregut, hindgut, or which one? Defective fusion of which parts of the gut? Third question that they will ask is, what are the clinical features that the patients will present with? And these are very peculiar clinical features that the child will come with. And one important question that they ask is, this is associated with what maternal conditions? Okay, so most of the times duodenal atresia is caught in small young neonates only, and as a result of this, what happens is you eventually find out from the maternal side that if these conditions are present in the mother, then there are higher chances of developing duodenal atresia. Okay, so first of all, can anyone tell me? Yes, very good, staphylococcus. So duodenal atresia is due to stenosis in D2, second part of the duodenum, and exactly if you want to know at which site, then it is at the level of the ampulla of Vater, at the level of ampulla of Vater. Okay, it is defective fusion of which two parts of the gut? It is defective fusion of the foregut and the midgut. What are the clinical features? Now, obviously, you are having a stenosis at D2. So, the food will not pass ahead from the first part of the duodenum to the third part of the duodenum. So, because of this, it is typically presenting like features of intestinal obstruction. So, the patient will present with vomiting. Okay. Now, it depends, this vomiting is bilious or non-bilious. You have to tell me that important thing. Will this be bilious vomiting or will this be non-bilious vomiting? Batao. Then, of course, since he is vomiting, he will have electrolyte imbalance, he will have dehydration, he will have drowsiness. All those normal things will be present. There will be dyselectrolytemia, there will be growth retardation because of undernutrition. Okay, so all those are normal things that you will see in duodenal atresia. But tell me, okay, staphylococcus is saying bilious vomiting. Alright, so it can be bilious or non-bilious vomiting. Now, sometimes the bile may mix at the ampulla of Vater into the duodenal substance. Sometimes the bile may not mix over there. So, depending on how high or low your obstruction is. If it is exactly at the level of the ampulla of Vater, bile will not mix. If it is just below the ampulla of Vater, then the bile will mix and you will get bilious vomiting. Okay, so it can be both bilious or non-bilious vomiting. So, don't get very confused about this saying नहीं bilious vomiting दे रहे तो ऐसा होना चाहिए, non bilious vomiting दे रहे तो ऐसा होना चाहिए. It can be both. Okay, alright. Now, what maternal condition is the duodenal atresia commonly associated with? So, if they ask you in the exam that the child comes with this kind of X-ray double bubble sign, and what could be possibly wrong with the mother during her pregnancy? So, what will your answer be? Very good. Polyhydramnios in the mother. Absolutely correct. So, maternal polyhydramnios. Okay. That is one maternal condition. What fetal condition is associated with duodenal atresia? This you should know. There is a syndrome which is commonly associated with duodenal atresia. Syndrome commonly associated, very good Ravi Shankar. So, Down syndrome is commonly associated with duodenal atresia. Okay, very good. Now, the next question that they will ask you in the exam is, what is the investigation that you do to find out duodenal atresia? Now, there are 2-3 investigations. You need to know the exact signs that you see in that case. So, one is your plain X-ray of the abdomen, in which we have already seen that there is double bubble sign. Barabar? One bubble is of the stomach and one bubble is of the first part of the duodenum, because your obstruction is at the level of the second part of the duodenum. Barabar? Now, the second investigation that is possible is USG. So, what is the sign that is seen on USG? And third is, is there any prenatal investigation that will help you identify duodenal atresia in the child? And finally, what is the surgery that you will do for duodenal atresia? All of you who have come in late, we are discussing duodenal atresia and all the associated questions regarding it that are asked in the exam. So what is the sign that you see on USG? Okay, very good, Chole Bhature. So you will see target sign. Okay, target sign, but this target sign is seen in many other conditions also. So it is also seen in case of CHPSS. It is also seen in one more condition which we'll be studying forward, which shows the target sign. Any prenatal investigation? Very good, Staphylococcus. So ultrasound of the abdomen of the mother. Okay, ultrasound abdomen of the mother can show you the fetus, and in the fetus you will be able to identify that there is duodenal atresia. Okay, so maternal and fetal ultrasound. Maternal and fetal ultrasound both will help you identify duodenal atresia. Okay, what is the surgery? Duodenojejunectomy. No, that's not correct, Staphylococcus. Okay, so imagine this is the first part of the duodenum, and this is the second part, and this is the third part, and this is the fourth part. Okay, now where is our obstruction? Obstruction is at this level, at the second part, correct? So what will you do? You will connect the first part of the duodenum to the third part of the duodenum directly. Okay, so this is called as duodenostomy. So you're connecting the first part of the duodenum to the third part of the duodenum. Okay, so this is called as duodenostomy. Now, sometimes along with this, what happens is in these patients, you can often also see there is malrotation of the gut. Okay, so you have opened up the abdomen anyways, you have done a laparotomy. So along with duodenostomy, you also derotate the gut. Okay, you also correct the malrotation of the gut. So if you do a duodenostomy and you correct the malrotation of the gut, then what is the name of the surgery? The name of the surgery is large operation. Okay, this is what comes in the exam. You should know this as a question. So if you do a duodenostomy plus you correct the malrotation of the gut, then this is called as your large operation. Okay. Alright, so this is all that they will ask you about duodenal atresia in the exam. Where is the stenosis? How does it present? What is the associated maternal conditions? And what are the investigations? What is the surgical repair? Okay, alright. So moving on to our next topic now. A 3-month-old child is brought to the casualty with vomiting, dehydration and drowsiness. This is the abdominal X-ray. Identify the disease. Meckel's diverticulum, duodenal atresia, CHPSS, Meconium Ileus. Tomorrow we'll be doing large intestine, and that will also be at 11 a.m. guys. Okay, are you guys sure this is congenital hypertrophic pyloric stenosis? Anyone? Okay, Dr. and Caffeine is saying D, Mulai Vendan is saying D, and Reshi is saying D. Barabar, everyone who's saying D, Meconium Ileus, that is the correct answer. Okay, so now this question that I asked you is absolutely the same, presentation is the same as this patient. Both of them present in young neonates, and that too they present with intestinal obstruction. Okay, the only difference is in the X-ray. So in that X-ray you can see double bubble sign. Here you can see the viscid paste like appearance of the meconium. Okay, so this is the meconium that is getting collected in the small bowel and it is obstructing the entire small bowel. Okay, so this is nothing but Meconium Ileus. So Meconium Ileus, what are the questions that are asked in the exam? Now, there is one key thing that I did not give you in this question because I wanted you guys to not know the answer very easily. I wanted you to identify from the X-ray. So the key thing is, what condition or what disease is Meconium Ileus associated with? What associated condition will you see in most of the patients with Meconium Ileus? Yeah, I stay very close by to a hospital, इसलिए ambulance की आवाज आती है. There is an autosomal recessive disease, and if they give you that, you should not even think 2 times. You should directly know the answer that this is Meconium Ileus. Fibrocystic disease of pancreas, very good, very good. So this is associated with cystic fibrosis. Barabar, cystic fibrosis. So in cystic fibrosis, what are the 3 things that will be affected? In cystic fibrosis, you will have involvement of the bronchioles of the lung. Okay, there will be cyst formation in the bronchioles of the lung. Second thing that you will have is you will have pancreatic involvement, which will lead to reduced exocrine hormone production. Okay, and the third thing that is present is you will have a large amount of sweat that is produced, and this sweat will contain a large amount of sodium in it. Okay, so this is about your cystic fibrosis. Yes, absolutely correct. That was the next question that I was going to ask. What is the gene that is mutated in cystic fibrosis? So it is your CFTR gene mutation that you see in cystic fibrosis. Okay, so the condition that is associated with Meconium ileus is nothing but cystic fibrosis, which will present with these three things. All right. Okay, now what is the normal presentation of Meconium ileus? So that is the next question that they ask. What is the clinical presentation? So they will present with all your normal signs of intestinal obstruction. So whatever we discussed now, dehydration, vomiting, dyselectrolytemia, drowsiness, all of those are the signs that are associated with Meconium ileus. Okay. Now, what is next question that is asked in the exam? So on plain X-ray of the abdomen, there is one sign that you see that is called as the soap bubble sign. Barabar, that is called as the soap bubble sign. What is soap bubble sign? Soap bubble sign is nothing but multiple air fluid levels. Okay. This sign is also given a scientist name. So can you tell me what is the name of the scientist after which this soap bubble sign is named? That is your question that can come in the exam. Okay, no one knows this answer. Yeah, the multiple air fluid levels will be seen. This is also called as soap bubble, because if you take a bubble bath, you will see multiple soap bubbles upper niche like that. Very good, Staphylococcus. So the name of that sign is Neuhauser sign. Okay. So that multiple soap bubble sign is also called as Neuhauser sign. So this can come in your exam. Neuhauser sign is seen in case of Meconium ileus. Okay. Now there is another test that we do, and that is the X-ray film test in case of. Now this is more for cystic fibrosis as compared to your Meconium ileus. So can you guys tell me what is done in the X-ray film test for cystic fibrosis? Anyone? What is the enzyme that is absent, which is important in the cystic fibrosis in this X-ray film test? Okay, so I will only tell you guys. So these two tests are specific for cystic fibrosis. Since we are talking about an associated condition, I am also discussing that with you guys over here. Okay, so in cystic fibrosis, what happens? The saliva of the patient contains less amount of trypsin. Okay, so trypsin is supposed to break down most of your proteins, your gelatins. So what you do is you take the vomitus of a patient who is suffering from cystic fibrosis and you put it on an X-ray film. Okay, now this X-ray film contains some gelatin on it. So that trypsin is supposed to break down the gelatin. Okay, but what is the problem? We have less amount of trypsin, or we have absent trypsin in case of cystic fibrosis. So as a result of this X-ray film test will be negative. So the gelatin in the X-ray film will not be broken down in case of cystic fibrosis. Okay, the second test that we have is your pilocarpine test. Okay, pilocarpine sweat test. So pilocarpine is nothing but a cholinergic drug. You give pilocarpine to the patient and he will start producing a lot of sweat. You collect that sweat and check the sweat for sodium levels. So if that sweat has high sodium levels, that means the patient may be suffering from cystic fibrosis. All right. So these are the two tests that are specific for cystic fibrosis. But if they ask you about anything about Meconium ileus, then this is the one that you need to be knowing, your Neuhauser sign. Okay. All right. Next question that they will ask you in the exam about Meconium ileus. What is the name of the surgery for Meconium ileus? Name of the surgery done for Meconium ileus? One very easy common sense question that is asked is what is the place where most of the meconium gets stuck, and that is obviously, since you know from the name, in the ileum. Okay, so which part of small intestine is involved? That is nothing but ileum. Yes, very good. So the name of the surgery which is done for Meconium Ileus is nothing but Bishop Coop operation. Barabar? Okay. Now, in Bishop Coop operation, what do you see? In Bishop Coop operation, what you do is, if the patient is having intestinal obstruction, you do nothing. You just dilate the segment which it contains all the meconium. Okay. So, suppose this part is containing all the meconium, you just cut this dilated segment, you resect this dilated segment, and you connect the other normal parts of the intestine to each other. So you're doing basically a resection anastomosis. You're resecting the part which is full of the meconium and you are connecting the other parts to each other. Okay, so that is called as Bishop Coop operation, done for Meconium Ileus. Alright, okay. So let's go on. There is one more treatment that you can do if you want to digest the meconium, if you want to make it thin, because it's thick paste like consistency. If you want to make it thin and you want it to pass in the bowel on its own, what you can do is you can give N-acetylcysteine irrigation. Okay, so N-acetylcysteine irrigation. N-acetylcysteine is supposed to break down the bonds of the substance of the meconium and make it thin so that it can pass out through the anus. Okay, so these are the two surgical options that you have. Alright, moving on to our next condition. A 6-month-old child is having severe abdominal pain and is crying constantly. The child has his knees drawn up to the chest. The mother says she has just started weaning the child from breast milk 2 days ago. This is the ultrasound abdomen report. What is the most common type of pathology in this patient? Ileocolic, colocolic, jejunal or gastroduodenal? Okay, so Ravi Shankar is saying answer is ileocolic. Any other answers? So what are we talking about over here? Even if you would have not read the question and just seen the ultrasonographic picture, or you just read the options, you can sort of make out what are we talking about over here. Very good, Pragya. So the condition is nothing but intussusception. Barabar, there is intussusception. So what is intussusception? Intussusception is nothing but invagination of one part of the bowel into the other part. Okay, so that sort of forms a small obstruction. You have the one part of the bowel, inner part and the middle part of the bowel, that goes into the outer part of the bowel. Okay, so that is called as intussusception. Now in intussusception, the questions that they ask are, first of all, you should be able to identify in what is the most common part that undergoes intussusception. Okay, so in children you have ileocolic intussusception most commonly, and in adults you have different. What is the intussusception seen in adults? Anyone? What is the telescoping or the intussusception seen in adults? Which part goes into which part commonly? Ileocecal. No, that's not correct. Okay, so colocolic, absolutely correct, Ravi Shankar. So in adults, you have colocolic intussusception. Okay, so the one part of the colon goes into the other part of the colon. So in children, we have ileocolic intussusception, while in adults, we have colocolic intussusception. Okay, now what is the most common age group in which you get intussusception? So this age group is very peculiar. It is 6 to 9 months of age. Any specific reason why at 6 to 9 months of age? In fact, it's given in the question also over here. The mother has just started weaning the child from breast milk 2 days ago. So this is seen commonly in patients in whom there is what? Yeah. So in patients whom you're weaning from breast milk, okay? So when you're weaning them from breast milk, what happens? There is inflammation of the Peyer's patches. So because of the weaning, you have a change in the diet, and because of the change in diet, your Peyer's patches become very, very active. So when these Peyer's patches become very, very active, they become inflamed, and as a result of this, one part of the intestine will go into or invaginate into the other part of the intestine. Okay, so mostly the inflamed part of the intestine will go into the uninflamed part. So that is where you get inflammation of Peyer's patches leading to intussusception. Okay, so the most common age group in which this happens is the age group in which you are weaning them from breast milk. Now, this can also happen in case of URTI. So, if the patient is suffering from upper respiratory tract infection, that can also lead to inflammation of the lymphatics all over the body. So, again, there can be Peyer's patches inflammation and you can have intussusception. Okay. Now, any one specific clinical feature that you guys can tell me which is very, very specific for this disease? There will be abdominal pain, there will be constipation, all these are generic answers. But any one specific sign that you see in them, in fact. Waxing, waning, okay, very good staphylococcus. So you will have red currant jelly stools. Okay, you will have red currant jelly stools passage in this case. So that is something which comes as a question in the exam. Now I have not put this in the case scenario because I wanted you guys to use your brains a little bit more, and that is why I didn't put the obvious things like red currant jelly stools. So you would have directly answered it. Okay, all right. The next question that they ask in the exam is, on palpation you find the right iliac fossa empty. So, what is the name of the sign? In this disease, on palpation, you will find the right iliac fossa empty. Anyone, do you know the name of the sign? So, the ileum is present on the right side, correct? So, the ileum is going into the colon. So, that's why you're not able to palpate that side. So, the right iliac fossa seems empty, completely empty. Yes, very good. So, this is called a sign of dance. Okay. So, this is the next question that comes in the exam. Now, next question that they can ask is, what are the complications? So normal जो intestine के होते हैं वो सभी है. You can have obstruction, you can have perforation, you can have peritonitis, all of those only. Okay, can you tell me what is the investigation in this case and what will it show you? Because there are very peculiar signs that you see in this disease, so that is why they can ask you this very easily. Okay, very good. So one though I have already given you, and that is on ultrasound. On ultrasound, you can see a bullseye sign or a target sign, correct? So on ultrasound, you can see a bullseye or a target sign. Barabar. Now, next one, can you tell me on in barium enema, what is the name of the sign that you see? On barium enema, very good. So on barium enema, what will you see? You will see a claw sign. Okay, and the third thing, on plain x-ray abdomen, what will you see? If I'm just doing a plain x-ray abdomen, what will I be able to see in that? Okay, so since this is nothing but an intestinal obstruction, what I will see in a plain x-ray is multiple air fluid levels because of the obstruction. Okay, so these are three important signs that you need to know: bullseye sign, target sign, claw sign, and multiple air fluid levels. Okay, what is the name of the surgery done for this condition? There is a peculiar name of the surgery done for this intussusception. What is the name of that surgery? Air enema. Yes, air enema is one of the things that you can give. So air enema is one of the options. You can push air through a flatus tube and allow, or a gastric tube, and allow the part which is invaginating inside to blow out. Okay, what is the second thing that you can do? Okay, another method that is used is called as Cope's method. So in Cope's method, what you do is nothing but you do a laparotomy and you milk out the part which has gone invagination. Okay, so you basically remove the part which has undergone invagination. So अगर ऐसा है तो उसको निकाल दो. All right. Okay. Now the question that they sometimes ask in the exam. This is something which is very important. Okay. So suppose this is the outer sheath and this is the part which has invaginated inside. So what is the part which is the outer sheath called as, and what is the part which is invaginating inside called as? Any idea? Very good. So the very good, doctor and caffeine. So the outer sheath, okay, the outer sheath is called as intussusceptions, and the inner and middle sheath that is there, which is going inside, this is called as the intussusceptum. Intussusceptum, okay, and the advancing part of this intussusceptum is called as the apex. So remember this. All right. So this is what you need to remember for your exam. Sometimes they can ask you, the outer sheath is called intussusceptions, the inner part is called as intussusceptum, and the part which advances is called as the apex. Okay. So everything is done about intussusception, most common occurrence, most common age group, what are the clinical features, what is the treatment, and what are the investigations. All right. So let's move on to our next topic now. A 35-year-old man from South India comes with left-sided abdominal pain, abdominal distension, and obstipation. This is his X-ray abdomen. Identify the next step. CT abdomen, conservative management, laparotomy, or laparoscopy. This is very easy. You just look at the X-ray and the answer is right in front of you. Okay, very good. So this is nothing but our volvulus, correct? So what is volvulus? Volvulus is nothing but you have twisting of one loop of the bowel over the other loop. Okay. So what will be your answer out of A, B, C, D? Okay, so laparotomy is the correct answer. Laparoscopically, you will not be able to untwist the bowel. Conservative management तो बिल्कुल नहीं करना चाहिए because that can lead to prolonged ischemia of the bowel and gangrene of the bowel. And CT abdomen करके you are not going to get anything new. Whatever you have got in the X-ray, that much is more than enough. Okay. So questions that are asked in the exam. Clockwise rotation of the bowel is seen in which volvulus, and anti-clockwise rotation of the bowel is seen in which volvulus? Important. Bata. And what is more common, clockwise or anti-clockwise? Ravi Shankar, in laparoscopy, you will be using minimal access surgery. So you will just be putting ports and a small camera and operating through those ports. In laparotomy, you are taking a full cut through the entire abdomen, through the rectus sheath, and opening up the entire abdomen. Okay, yes, very good. So anti-clockwise rotation is more common, and this is called as sigmoid volvulus. So sigmoid colon is twisting over here, and when you have clockwise rotation, C for clockwise and C for cecal. Okay, so your cecum is rotating, and that is seen in cecal volvulus. Okay, now let's study a little bit about sigmoid volvulus. In which part of India is it most commonly seen? That is one question that they can ask you. You know, NBE always likes to ask some hatke questions. So if they want to ask you some direct question from the textbook, this is one of the questions that they will ask. In which part of India is sigmoid volvulus more common? Okay, Then how many turns of the bowel takes place? So how many anti-clockwise turns of the bowel will take place, and what are the clinical features that you see? Okay, very good, Faiz Ibrahim. So he's saying that in South India, there is maximum chance of sigmoid volvulus because they eat a lot of rice. Okay, so they eat a lot of high fiber diet. So patients who eat high fiber diet are more prone to volvulus or twisting of the bowel. Okay, how many turns of the bowel take place? 3 turns. Are you sure, Faiz? Is it 3 turns? Okay, usually it is only 1 turn of the bowel. If it is about 1.5 turns of the bowel, then this can lead to vascular compromise. Okay, so if it turns once on itself plus a little bit more, the entire blood supply to the bowel will get affected and there will be ischemia and the bowel will become gangrenous. Okay, so it just 1.5 turns can also lead to vascular compromise. Okay, and then next is clinical features. So the clinical features very easy. There is entire bowel is blown up like this, it is distended, there is obstruction, so all signs of obstruction will be there. Okay, so there will be distended abdomen, there will be obstipation, and there will be a tympanic note all over the bowel. And और भी क्या होता है, vomiting भी होता है ना, vomiting and obstipation is there in all cases. Along with that, you will see abdominal distension and a tympanic note all over the abdomen. Okay, all right. Now let's come to the specific investigations. These questions are asked many times in the exam. Okay, so on plain X-ray, what is the name on plain X-ray? What is the name of the sign that you see in case of sigmoid volvulus? 2 signs. Very good. One sign is called as omega sign, and the second sign is also called as, everyone knows this, coffee bean sign. And there is one more name. One more name that is called as bent inner tube sign. Okay, so you can also say bent inner tube sign. Okay, so these are the 3 signs that you see on X-ray: coffee bean sign, bent inner tube sign, or omega sign. All of them are same. Okay, now suppose I do a CT scan. Then what is the appearance of the dilated bowel loops? What is the name of that appearance on CT scan? And on barium enema, what is the name of the appearance? Okay, very good, Chole Bhature. So on CT scan, the name of the sign is whirl sign, like a whirlpool. Okay, or like washing machine whirlpool होती है ना, उसमें कपड़े कैसे घूमते हैं वैसे. So like a whirl. Or the on barium enema, what is the name of the sign? Very good. So yeah, so this is the picture of the barium enema that you can see. Okay, so can you see over here? Just see how I trace. The barium has filled this entire area. This is the entire distended bowel, and इसका tip यहाँ पे ऐसे दिखाई दे रहा है. Okay, so this tip that is seen is called, looks like the bird beak. Okay, so this is also called as bird beak appearance. Bird beak appearance on barium enema. So in the exam, be very careful. If they give you bird beak appearance on barium enema, it is sigmoid volvulus. If you get bird beak appearance on barium swallow, then what are we talking about? Bird beak appearance on barium swallow? Very good. Achalasia cardia. Okay. So I know all of you all will be very nervous during the exam. So please don't get in that nervousness. Read properly, because they will give you both the options. Okay. They will give you on barium enema and they will give you both options, sigmoid volvulus as well as achalasia cardia, and at least 50% will mark it as achalasia cardia and come. Okay. So अच्छे से question पढ़ना even if you are nervous, because these are simple questions which you can get your marks on and it can increase your rank by crazy numbers. Okay, so जो आंसर आता है कम से कम वो बराबर से मार्क करके आओ. Okay, now what is the treatment and what is the surgery? So before you take up this patient for surgery, because of the obstipation, constipation, vomiting, dehydration, he will be not very optimal for surgery. Okay, so what you do is two things. One, you can pass a flatus tube or a sigmoidoscope, and you can reduce the distension that is there in the entire sigmoid bowel. Okay, second thing, antibiotics and IV fluids to optimize the patient for surgery. Okay, and what is the surgery that you will do? What is the name of the surgery? Yeah, so what you do is nothing. You do a laparotomy, you untwist the bowel and you fix the bowel. Okay, you have to fix the sigmoid colon so that it does not twist again on its axis. So that twisting is, that fixing is called as sigmoidopexy. Okay, the second thing that you will do is, suppose the bowel has turned gangrene. Okay, so if it has turned gangrenous, what you do is you have to cut out the unhealthy part of the bowel. Okay, the healthy part of the bowel, you will bring it out as a colostomy, and the remaining distal end that is there, you will bring it out as the mucus fistula. Okay, because that part will not contain any stools. The distal part will not have any stools in it anymore. So the proximal part, you will bring it out as a colostomy. So all the stools will come out from the colostomy into the stoma bag, and the distal part will just have mucus coming out of it. So that is called as mucus fistula. Okay, what is the name of that surgery? Anyone? Name of that surgery? This is called as Paul Mikulic's operation. Paul Mikulic's operation. Okay, got it? So after 6 weeks, you can again bring both the proximal and distal end inside and join it. But right now, when the bowel is unhealthy, you will do a Paul Mikulic's operation. So this is everything that you need to know about volvulus, sigmoid volvulus as well as cecal volvulus to be able to identify in the exam. और कोई question नहीं पूछते about it. Okay? Alright. Moving on to our next question. Now, in Hartmann surgery, you completely close the lower end. You don't form a mucus fistula. You completely. हाँ, छोले भटूरे, ये सब नाम याद रखने हैं सर्जरी के, बिकॉज ये सब एकदम स्पेसिफिक नेम्स है. लिटरली सब पैथोलॉजीज के नाम नहीं याद रखने हैं सर्जरी के लिए, बट some of them you have to remember because these are topics that are asked again and again in the exam. Okay, all right. A 40-year-old male is recently operated for typhoid ulcer perforation. On post-op day 2, he has not passed stools, he has distended abdomen and absent bowel sounds. Which blood investigation will you send in him? Okay, तो अभी भाई साहब का टाइफॉइड अल्सर परफोरेशन रिपेयर सर्जरी हुआ है. You have closed the perforation, and since 2 days he has not passed any stools. So you know how Indians become absolutely agitated whenever there are any bowel related problems. So all of us will always be looking for some kind of answer for the question. So 2 दिन हो गए हैं and the patient has not passed any stools. He is very scared. So he is saying कि my abdomen is feeling distended, I am feeling very uncomfortable. So what investigation should be sent? Serum sodium and magnesium, serum potassium, CBC or LFT-RFT. Very good. Very good, Faiz. Very good, everyone. Everyone has answered serum potassium. That is absolutely correct. So post-operatively, what is the cause of this constipation that is happening? It is paralytic ileus. Bilkul barabar answer. Okay, so now let's see a few questions about paralytic ileus. Now, can anyone tell me the pathology of paralytic ileus? Why does paralytic ileus occur? What is the pathological problem in it? The second thing is, what are the common causes? So most common cause is usually surgery. So post-operatively you will see it. What are the clinical features of paralytic ileus? बताओ. Okay, so paralytic ileus is basically you have no peristalsis of the intestine. Okay, And what is responsible for this? Your peristalsis of the intestine is mainly coordinated by your Orbax plexus. I had told you na, myenteric plexus of Orbac and submucous plexus of Messner. So these are your two intrinsic mechanism of regulating the bowel peristalsis. So both of these are not working. And why are they not working? Because of many things. Because of hypokalemia, because of infection, because of bile leak. Okay, so this neuromuscular mechanism is affected, and as a result of this there is absent peristalsis of the bowel. Okay, yeah. So what are the clinical features in this case? What will the patient present with? There will be complete no passage of stools and no passage of flatus also. So that is commonly also called as obstipation. Okay. Second thing, there will be no bowel sounds. ठीक है, bowel का peristalsis हो ही नहीं रहा है, तो how will you hear any bowel sounds, correct? Now this bowel will be full of air in it, so there will be abdominal distension because of that, because it's completely full of air. Okay, and there, because the intestinal contents are not moving forward, if they are not moving forward, what will happen? They will come up. Okay, so there will be vomiting. तो वेरी सिमिलर फीचर्स, ये जो सारे हमने पैथोलॉजीज किए हैं ना, दिस इज फ्रॉम दैट चैप्टर ऑफ इंटेस्टिनल ऑब्स्ट्रक्शन ओनली. सो दैट इज व्हाई ऑल ऑफ देम प्रेजेंट विद ऑलमोस्ट द सेम फीचर्स. ऑल ऑफ देम विल हैव वॉमिटिंग, डिहाइड्रेशन, डिसेलेक्ट्रोलाइटेमिया, obstipation and abdominal distension and no bowel sounds. All of them will have similar presentation. You just need to be able to identify very small points like red currant jelly stools किसमें दिखाई देता है, like post-op patient में what is the more likely cause of intestinal obstruction that will happen. Okay, so all of them. Okay, now next thing that they'll ask is what are the investigations. So one investigation I'll give you, serum potassium you will send. Any other investigations? One very commonly done bedside investigation that we do is USG abdomen. Okay, so you'll want to do a USG abdomen to rule out are there any other causes of abdominal distension. Is there an obstruction? Is there a perforation? Is there something which is wrong, which you are not picking up on clinical picture? So what will you, USG abdomen will just show dilated bowel loops, and in fact ultrasound will not show you a very nice picture because the dilated bowel loops are full of air in them. Okay, so ultrasound does not conduct very well through the air, so you will not be able to see a very nice echogenic picture on ultrasound. Okay, if you do an X-ray picture on X-ray abdomen, you will be able to see dilated bowel loops with multiple air fluid levels. Okay, what is the treatment in case of paralytic ileus? Nothing. Treat the cause. ठीक है, simple, you have to treat the cause. ज़्यादा अगर air भर गया, if there's too much dilatation of the bowel, if there's too much air in the bowel, then you can remove the air by Ryle's tube aspiration. You can empty the air by Ryle's tube aspiration. Other thing that you can do if you want to induce the peristalsis in the bowel, you can use some yeah, and because the patient is dehydrated, you will also give him IV fluids, you will also catheterize him, and you will continue to monitor him. Okay, catheterization will also help you to rule out if there is any cause like sepsis by looking at the hourly urine output. Okay, so this is all about paralytic ileus. ज़्यादा कुछ पूछते नहीं है एग्जाम में about paralytic ileus, but इतना तो पूछते ही हैं. ठीक है, जितना मैंने तुमको बताया है उतना तो पूछते हैं, और कुछ नहीं जानने की जरूरत है. Okay, all right. Moving on to our next question. Identify this sign and in which condition is it seen? Polycystitis, Crohn's disease, intestinal obstruction, or acute appendicitis? Okay, so 1, 2, 3 are saying appendicitis. So what is the sign and what is the name of the sign? You palpate in the left lower quadrant and you get migratory pain in the right lower quadrant. What is the name of the sign? Very good. So the name of the sign is nothing but Rovsing sign. Okay. This is called as Rovsing sign. And this Rovsing sign is seen in acute appendicitis. Okay. Yeah, absolutely correct. So you palpate in the left lower quadrant and you're getting pain in the right lower quadrant. So this is seen in acute appendicitis, also called as Rovsing sign. Okay. All right. Now, what are the questions that are asked about acute appendicitis? Questions asked about acute appendicitis. The first question that they will ask is most common organism causing acute appendicitis. So in that is the first question. The second question that they will ask is organism causing pseudoappendicitis. Okay. Now, the third question that they will ask is what are the types of acute appendicitis? Okay, so there are three types of acute appendicitis. So you should be knowing all those three types of acute appendicitis. And the fourth question that they will ask you is what is Murphy's stride? Okay, so चलो स्टार्टिंग से आंसर बताओ. What is the most common organism causing acute appendicitis? Yes, absolutely correct. So the most common cause of acute appendicitis is E. coli. Okay. Then what is the organism causing pseudoappendicitis? So why do we call it as pseudoappendicitis? Pseudoappendicitis is basically if there is Yersinia infection of the ileum. Okay, Yersinia infection of the ileum that leads to ileitis, and then that infection spreads to the appendix causing appendicitis. Okay, so that's why it's called as pseudoappendicitis. It's actually an extension of the infection from the ileum to the appendix. Okay, in which disease do we commonly see this? Raghuvansh Tripathi, in which disease do we commonly see pseudoappendicitis? Any disease of the small intestine that causes it? Okay, so you commonly see this in Crohn's disease. Okay, this Yersinia infection of the ileum often occurs in Crohn's disease because Crohn's disease also involves ulcers of the ileum. Okay, alright. Now you have three types of acute appendicitis. Can anyone tell me any one type? Any one type भी बता दो बस हो जाएगा. Okay, good staphylococcus. One of the types is obstructive appendicitis. Okay, so if you have any fecalith, okay, a ball of feces that is obstructing the lumen of the appendix that can later cause inflammation of the appendix, that is called as obstructive appendicitis. Okay. Second type of appendicitis, very good staphylococcus, catarrhal appendicitis, that is also commonly called as mucosal appendicitis. Okay, that is nothing but simply inflammation of the mucous membranes of the appendix. Okay, so your appendix appendiceal mucous membranes will show redness and edema. So that is your acute catarrhal or mucosal appendicitis. And the third type of appendicitis that we have, third type of appendicitis, very good. So the third type of appendicitis that we have is recurrent appendicitis. Okay, acute recurrent appendicitis. So this is when a patient has repeated attacks of appendicitis. Okay, so that is your third type of acute appendicitis, and we have one more type, and that is called as stump appendicitis. Any idea what could be stump appendicitis? Okay, so after you do a laparoscopic appendicectomy, usually if you leave the stump behind, okay, and if the stump gets secondarily infected, then that is called as stump appendicitis. Okay, so these are all our this stump appendicitis is in fact one of the subsets of recurrent appendicitis. Okay, so recurrent appendicitis means it's happening for the second time. So this stump appendicitis is one of the subsets of recurrent appendicitis. So the three main causes of acute appendicitis are mucosal appendicitis, obstructive appendicitis, and recurrent appendicitis. Okay, moving on to the next more frequently asked question the most important question in the entire class. What are the, yes, it is seen after laparoscopic appendicectomy. What are the three things in Murphy's sign? Murphy's stride. What are the three parts of Murphy's stride? Batao. Patient presentation is nothing but Murphy's stride in acute appendicitis. Pain, vomiting and fever, barabar. What is the first sign to occur? Pain, vomiting, fever. What is the first sign to occur? First sign to occur is pain, second sign to occur is vomiting, and third sign to occur is fever. Okay, so these are the clinical features of acute appendicitis. Okay, all right. Now, the next question that they will ask are about the peculiar signs that you see with appendicitis. So, one sign we already saw, that was the Rovsing sign. Rovsing sign may, I showed you, you palpate the left lower quadrant and you get pain in the right lower quadrant. Okay. Now, there is another sign and that is called as Bloomberg sign. So, can anyone tell me what is Bloomberg sign? We in fact did it in our last class. Bloomberg sign. In our last class of science in medicine, we did this Bloomberg sign. Very good. Bloomberg sign is nothing but sign of rebound tenderness. So you press over the McBurney's point in the right iliac fossa, and then when you release, the inflamed appendix will hit against the palpating hand. So the patient will get pain on release. That is called as rebound tenderness. Barabar? Okay. Then in retrocecal appendix, we have something which is called as Cope's sign. Any idea what is that? Cope's sign. Cope's sign specifically seen in retrocecal appendix. कुछ idea है? Okay. So when you hyperextend the legs of the patient, okay, on hyperextension of the legs, what will happen? The appendix will hit against the psoas muscle, okay, and as a result of this movement, this hyperextension can cause excessive pain to the patient at the McBurney's point. Okay, so hyperextension of the hip can lead to pain in a retrocecal appendix. Okay, so that is your Cope sign. All right, now next thing that they will ask you in the exam is, what is the scoring system used for acute appendicitis? What is the name of the scoring system used for acute appendicitis? But psoas sign is Cope sign only, Rita. Very good. So the scoring system that is used for acute appendicitis is called as the Alvarado scoring system. Very good. Alvarado scoring system. Okay. Can you tell me 2-3 things that are seen in the Alvarado scoring system? Anyone? Anything that you see specifically in the Alvarado scoring system? Okay. Tab tak batao what will be the investigation? What is the investigation that you will do to identify acute appendicitis? Something that is readily available. It will give you an accurate answer. It is cheap. Yes, very good. So the investigation of choice will be ultrasound of the abdomen. Okay, that is the best investigation, easily available, cheap, and it will give you the accurate answer. Okay, all right. Next question that they ask in the exam is, what is the treatment? Okay, now treatment, as all of us know, is nothing but appendicectomy. Now overall, the most common thing that is done now is laparoscopic appendicectomy, minimally invasive surgery. But sometimes they ask different incisions. The older examiners that are there, they may ask you the different types of incisions that are seen in appendicectomy. So I've put a picture for you guys over here to identify. Okay, So this is your McBurney's point. So your McBurney's point is nothing but if you draw a line from your ASIS to your umbilicus, okay? Then mark a point which is at lateral 1/3 and medial 2/3. Lateral 1/3, medial 2/3. Okay, from that line, so that will be called as that point will be called as McBurney's point. Okay. Now, so first incision that we have is along the McBurney's point, so that is called as McBurney's incision. Other than that, what are the incisions that we have? Anyone? Yeah. So we have the modified McBurney's incision that is taken along the lines of Langer of the skin. Okay, so that is your modified McBurney's incision. Then the next incision that you have is your Rutherford-Morrison incision. Okay, so your Rutherford-Morrison is basically it will cut the muscles. So that is your muscle cutting incision. ऐसे ही नाम याद रखो, Rutherford Morrison muscle cutting incision. Okay, modified McBurney's lines or lines of Langer incision. Then any other one that we have? Okay, now extension of this Rutherford Morrison is called as Fowler-Weir extension. Okay, so Fowler-Weir extension is nothing but you're extending the Rutherford Morrison incision more towards the umbilicus. So you're taking it more towards the midline. Again, you're cutting the muscle over here. So this is Fowler-Weir is also a muscle cutting incision. Okay. Alright, so these are the important incisions that are asked about appendix in your exam, and this is appendicectomy in your exam, and this is what you need to remember. But remember, most commonly what we use nowadays is nothing but laparoscopic appendicectomy. Okay, alright. Now, tired of talking so much. Now, there are three things that you need to know in relation to an appendix, not just appendicitis, but also appendicular lumps or appendicular masses. Okay, so we have different types of appendicular masses. So now just look at the picture that you see over here and tell me if you get a picture like this of an inflamed appendix along with pus, what could it mostly be? So I'm giving you the features of this patient. He is having high fever and he is looking very toxic. Okay, toxic means he's looking extremely ill and he is having a soft swelling in the right iliac fossa. If these three features are present and you can see pus on laparoscopy, what is this called as? Very good, doctor and caffeine. So this is called as appendicular abscess. Appendicular abscess. Okay. Now, what will you do in this case? First thing you will do is you have to settle the abscess. So you will start antibiotics in this patient. Second thing that you will do is you can do a CT guided drainage of the pus. Okay. And once the pus settles and everything in the area settles down, the inflammation comes down a little bit, then you can do an interval appendicectomy in the patient after some time. Okay, mostly this interval appendicectomy is done after 3 months. So only once the pus has settled, then you will do an interval appendicectomy. Okay, because during this phase, when the pus and everything is there, there will be a lot of inflammation. You will not be able to identify between the different tissues and you might not be able to do an effective appendicectomy. Okay, so you will do an interval appendicectomy once the inflammation has settled after 3 months. Okay, and there will be a lot of adhesions also during the acute case. So you will avoid doing an appendicectomy during that time. Okay, now next one is, suppose I do an appendicectomy. Okay, so once you do an appendicectomy and you remove the mass and then you open up or you cut the appendix and you check inside it and you see that there is production of mucus in it. Okay, so what is this called as? There is sterile fluid, there is mucus that is present, sterile mucus that is present inside the appendix, appendicular mass. What is this called? Yes, so this is nothing but a mucocele of the appendix. Okay, this is called as a mucocele of the appendix. Okay, Alright, so what will you do in the mucosal of the appendix? You have already removed the appendix, so you don't need to do anything else for it. Okay? Okay. Now, the next question that they asked about appendicitis is, usually interval appendicectomy is done after how many weeks? This is the last question about appendicectomy. Interval appendicectomy is usually done after how many weeks? तो बताओ. Very good. So it is usually done after 6 weeks. Okay. Interval appendicectomy is usually done after 6 weeks. Okay. Alright. So now we have done everything about the appendix and all different types of intestinal obstruction. Now let's move on to the remaining part of small intestine that we had from yesterday's class. Okay, so here goes the question. A patient was recently operated for intussusception. This is a picture of his follow-up endoscopy. What condition could he be suffering from? HNPCC, Willis adenoma, hemangioma of small intestine, or Brunner gland adenoma? Okay. Yes, very good. So I can see there are a lot of confusing answers between everyone. So the correct answer for this is nothing but, sorry. Lot of confusing answers between everyone. Yeah, so this is nothing but, this is Peutz-Jeghers syndrome. Oh shit, I forgot to put the correct answer only. That's what I was looking over here, that I've forgotten to actually put the correct option. So this is Peutz-Jeghers syndrome. Okay, guys. So what do you see in Peutz-Jeghers syndrome? In Peutz-Jeghers syndrome, it is nothing but, first of all, tell me what is the inheritance of that disease? What is the inheritance of this disease? Anyone? Is it autosomal recessive, autosomal dominant, X-linked disease? Okay. Then what are the important clinical features? So what you will see is one thing that I've put in the picture over here. So the patient will be having brownish black pigmentation along the lips. Along the lips and also the mucous membrane. So if you ask them to open the mouth now, there will be the same freckles that will be present inside. Autosomal recessive, autosomal dominant, recite करो अपने आप में. Okay, yes, so these are autosomal dominant disease. Okay, and then what will also the patient have? Then he will have these small polyps that are present. Okay, and these polyps are present all throughout the jejunum and the ileum. All throughout the jejunum and the ileum, he will be having these hamartomas. Okay, so this is how you identify Peutz-Jeghers disease. This is very easy to identify. This is one of the easiest questions that can come in your exam. So just remember polyp plus brownish black pigmentation, Peutz-Jeghers syndrome. Okay, all right. Okay, moving on to the next question. Which of these is the most common malignant tumor of the small intestine? Read the question carefully. I am asking you about malignant tumor of small intestine. Most common malignant tumor of small intestine: non-Hodgkin's lymphoma, just adenocarcinoma, or carcinoid. Very good. Doctor and caffeine, excellent. Ravi Shankar, excellent. No, Ravi Shankar, not excellent. You have written answer as C. So carcinoid is not the answer. The correct answer is D, adenocarcinoma. Okay, so most common malignant tumor of the small intestine is nothing but adenocarcinoma of the small intestine. Okay, all right. So in this, they will ask you few questions about the malignancies of the small intestine. Okay, so all these options that I gave you in the previous question, na, Willis adenoma, hemangioma of small intestine, Brunner gland adenoma, HNPCC, all of these are benign tumors of small intestine. Okay, and these options that I've given you in this question, NHL, GIST, carcinoid, adenoma, all of these are malignant tumors of small intestine. Okay, so out of these, adenocarcinoma is the most common. Can you tell me which is the most rare out of all of these? Which is the most rare malignant tumor out of all of these? स्क्वामस, स्क्वामस कहाँ से आया? ये चारों में से सबसे रेयर कौन सा है? These four are the malignant tumors. NHL, no. Okay, so it is nothing but your GIST. Okay, GIST is the most rare malignant tumor out of all the following. So most common is adenocarcinoma and most rare is GIST, malignant tumor of small intestine. Okay, अभी adenocarcinoma के बारे में they will ask you, it is associated with, give me 2-3 diseases or syndromes that it is associated with, and the second thing that they will ask you is most common site of adenocarcinoma in the small intestine, and then surgical ट्रीटमेंट तो सबका वही है, जिधर भी देर विल बी अ ट्यूमर यू विल डू अ रिसेक्शन एंड अनास्टमोसिस, वो तुम ओवरऑल वैसे याद रखो, ठीक है. रेडियोथेरेपी, कीमोथेरेपी, yes, it can be given in small bowel tumors, but I don't think there's nothing specific in them for them to ask you. So what they will ask you is the questions that I'm asking you. Okay, so adenocarcinoma is associated with which disease? Okay, very good, doctor and caffeine. So it is associated with familial adenomatous polyposis, and second disease that it is commonly associated with is Crohn's disease. ठीक है, so ये दो diseases में you will have formation of adenocarcinoma of colon whenever there is a malignant transformation. Okay, how will you confirm the diagnosis? You can do an endoscopy and biopsy. How will you treat resection and anastomosis? What is the most common site of adenocarcinoma? It is in the duodenum and jejunum. ठीक है, बेसिकली आइलियम में नहीं है, वो डिओडनम एंड जेजुनम में है. ओके, नाउ नेक्स्ट वन दैट वी हैव इज नॉन हॉजकिंस लिम्फोमा. सो नॉन हॉजकिंस लिम्फोमा में दे विल आस्क यू द मोस्ट कॉमन साइट ऑफ NHL is nothing but lymph nodes. बराबर, overall in the entire body most common site of non-Hodgkin's lymphoma is in the lymph nodes. Now most common extranodal site, extra lymph nodal site is GI tract. Okay, most common extranodal site is GI tract, so remember that. And GIT में the small bowel is the most common site. Okay, the next question that they will ask you is which type is more common? Is it B cell type or is it T cell type? Which type of NHL is more common, B cell type or T cell type? That is the only question that they will ask. So just remember the B cell type is more common. Okay, next you have your carcinoid tumor that we'll be discussing in detail ahead. So I'm not discussing it with you guys over here, but it is quite common malignant tumor of the small intestine. And last we have GIST, gastrointestinal stromal tumor. Yesterday only I discussed GIST with you guys. So can you tell me what is the most common site of GIST in the entire GI tract? पूरा GIST हमने कल किया था. What is the most common site of GIST in the GI tract? Very good, doctor and caffeine. So stomach is the most common site of GIST in the GI tract. Very good. Okay, now let's discuss a little bit about carcinoid tumors. Okay, so questions that are asked about carcinoid tumor. From which cells do they arise? That is the first question asked. Okay. Then the second question asked is what do they secrete? Third question that they ask is most common site of carcinoid tumor. And fourth question that they ask is what are the most common hormones secreted by carcinoid tumor. And next question is which syndrome is it associated with? Okay, very good. They arise from the enterochromaffin cells. Okay, and where are these enterochromaffin cells found in the small intestine? They are found in the crypts of Lieberkühn. Okay, they are found in the crypts of Lieberkühn. Perfect. Then what do they secrete? They are neuroendocrine cells. What? Very good. So what do they secrete? They secrete vasoactive peptides. Okay, they secrete vasoactive peptides. So all your hormones, na, serotonin, VIP, vasoactive intestinal peptide, then dopamine, histamine, all of these are vasoactive peptides. Vasoactive means they act on the blood vessel, correct? So peptides or protein cells that act on the protein compounds that act on the blood vessels. So all of these are secreted by carcinoid tumor. What is the most common site of carcinoid tumor? Most common site of carcinoid tumor, guys? Yeah, doctor and caffeine, your one answer is correct. The most common hormone secreted by carcinoid tumor is your serotonin. Okay, overall, most common. Yeah. And the most common site of carcinoid tumor is in the appendix. Absolutely correct. Which syndrome is associated with carcinoid? Any syndromes associated with it? Okay, so the MEN syndrome is associated with carcinoid tumor of the small intestine. Okay, you have to tell me which type of MEN syndrome is associated with it. Okay, other than serotonin, there are also other vasoactive peptides that are secreted by carcinoid. So you have histamine, you have dopamine, you have pancreatic polypeptides. Okay, so many things are secreted, but mainly you need to remember serotonin. That's why the patient presents with excessive watery diarrhea. Okay, because of excessive serotonin release. Which MEN syndrome is associated with it? MEN 1, MEN 2, MEN 3, 4, 5, 10. Okay. बताओ मुझे तब तक I will discuss the next part. Okay, what are the clinical features, striking clinical features in a carcinoid? So one striking clinical feature that you have in a carcinoid is that the patient will present with diarrhea. Correct? He'll present with watery diarrhea because of excessive production of serotonin. Okay, and also if the patient has excessive release of serotonin into the circulation, there will be flushing of his face, there will be cyanosis, there will be asthmatic attacks. So that is called as carcinoid syndrome. That is due to excessive release of serotonin into the surrounding, into the blood vessels. Okay. Okay, MEN type 1 is associated. MEN syndrome 1 is associated with carcinoid of the small intestine. Okay, so if your patient that they give in the exam is presenting with watery diarrhea, flushing of the face, bronchospasm, then all this is due to release of excessive serotonin from carcinoid. All right. Okay. Then next question. Which of these is the most common secretion of carcinoid tumor? I gave you guys the answer. Iska. Pele only. Okay. So answer is serotonin. Alright. So we know the answer to this is serotonin already. Okay. Now, the next thing that they will ask is how do you investigate a carcinoid tumor? So can you tell me what is the investigation that you will do if they give you this question that a patient comes with flushing, bronchospasm and watery diarrhea since the past 3 months, and what is the investigation that you would like to do in this patient to confirm the diagnosis? Now, these 3 words will definitely give you the answer as carcinoid. You need to tell me what will be your next step. बताओ. Very good, doctor. And caffeine. So you will be checking the levels of 5-HIA, which is the metabolic product of serotonin. Okay. But where will you check 5-HIA levels? In which sample will you check 5-HIA levels? Very good. So in the urine sample. Okay. So you will check urine secretion of 5-HIA over 24 hours. Alright. Now they don't really ask you what is the normal value of it, but usually 2 to 8 mg per 24 hours or per day is the normal value of 5-HIA that can be asked in the exam. If you don't understand what has to be marked as the answer, if you don't know about 5-HIA, you just think about it. There is some mass that is present in the small intestine. What radiological investigation will help you find that mass? इतना डीप में जाने की जरूरत नहीं है. सिंपल बताओ, what will help you find? Any idea? Very good, Rita. So that is, sometimes you also need to think simply, logically. Okay. कुछ भी मास है, कुछ भी ट्यूमर है, कुछ भी lesion है in the small intestine, how will you find it out? You can find it out by CT or you can find it out by endoscopy. Okay. So you will also know about carcinoid by doing a CT scan if there is a big mass that is present. Okay. Now, sometimes they will ask you nuclear medicine. He is sent to the nuclear medicine department. So which radioactive isotopes will be used for identifying the tumor? Any radioactive isotopes used for identifying carcinoid? And the last thing, in the serum, there is something that will help you identify. Okay, gallium scan, not really, but iodine 131 scan. Okay, so sorry, ulta likh diya maine. Iodine 131 scan will also help you identify the presence of carcinoid. Okay, and there's one more octreotide scan, 111 octreotide scan, that will also help you identify presence of a carcinoid tumor. Okay, and last question that they will ask is serum levels of which compound will be increased. So your serum levels of chromogranin A will be elevated in case of carcinoid syndrome. All right. Okay. Okay. Now, the next thing that they will ask you is what is the treatment? Treatment batao kya hoga? Simply, I'm asking you what is the treatment? Did we discuss about the, most common site is the appendix. Okay. Batao, what will be the treatment? Debulking surgery. Okay. There is a carcinoid tumor. What do you have to do? Remove the tumor and do resection and anastomosis of the rest of the part. But now it depends where is your carcinoid tumor present. Okay. So since we said that appendix is the most common site of carcinoid tumor. So if in the appendix you have a carcinoid tumor, how will you remove the carcinoid tumor? What is the surgery you will do in this case? Simply socho, logically socho. एकदम easy answer है. अपेंडिक्स में कुछ प्रॉब्लम है, क्या करोगे तुम? अपेंडिक्स निकाल दोगे? अरे मोनोक्लोनल एंटीबॉडी नहीं है, आई एम आस्किंग सर्जिकल ट्रीटमेंट. वेरी सिंपल गाइज. अपेंडिक्स में अगर कुछ प्रॉब्लम है तो तुम अपेंडिसेक्टमी करोगे, बराबर? Yeah, you will do an appendicectomy. But remember, here we are talking about a tumor. Okay, so sometimes the tumor may be aggressive. So if the size of the tumor is less than 2 centimeter, size of the carcinoid less than 2 centimeter, you can do appendicectomy, get away with it. Okay, if the tumor is big in size, it is more than 2 centimeter, then you also have to remove the adjacent part of the colon. So you will do a right hemicolectomy if it is more than 2 centimeter in size or if it is involving the base of the appendix. ठीक है, यहाँ पे देखो, इधर दिखाती हूँ तुमको फोटो में. ये देखो, अगर तुम्हारा टिप ऑफ द अपेंडिक्स इन्वॉल्व है, सपोज यहाँ पे, यू कैन इजीली जस्ट remove the appendix, do an appendicectomy, get lost with the tumor. Okay, but suppose it is involving the base of the appendix, that means it may have also spread to the colon. So what will you do in that case? You will remove the appendix, you'll do an appendicectomy, plus the adjacent part of the colon also you will remove. So you will do a right hemicolectomy in that case. Okay, all right. And also the bigger tumors more than 2 centimeter in size also you will do a right hemicolectomy. Okay, okay, all right. Now the next one, suppose you have a small bowel carcinoid, then what will be your treatment? Again, it depends on the size of the carcinoid. Okay, whether it is less than 1 centimeter, whether it is more than 1 centimeter in size. So if it is less than 1 centimeter, you can just remove that segment of the small intestine. Okay, itna sa agar tumor hai, just take a good margin and remove that much part of the small intestine. So you can just do a wide excision. Okay, but if the tumor is big in size, if it is more than 1 centimeter in size, that means it is aggressive. So here what only wide excision will not do, you will do a radical excision in this case. So in radical excision, you will remove the part of the tumor with the surrounding mesentery. Okay, so you will also remove the surrounding mesentery so that the recurrence of the tumor is reduced. Okay, understood? So this is about carcinoid, and there are also some monoclonal antibodies that we use for treatment of carcinoid. Any idea of any names of monoclonal antibodies? कुछ नाम पता है किसी को भी? Any one? Any one monoclonal antibody, tell me. Okay, sunitinib, very good. Anything else? Bevakizumab and one more is there, that is everolimus. Okay, these are the monoclonal antibodies used for treatment of carcinoid. The other thing you can also use is somatostatin analog. You can also use somatostatin analog. So which are these somatostatin analog? This is nothing but octreotide. And octreotide का एक और भाई आता है, उसका नाम is pasireotide. Okay, so these are all the somatostatin analogs that you can use. And other than that, if production is histamine, you can use antihistaminics. If production is dopamine, you can use antidopaminergics for your treatment. All right, so this is all about carcinoid. So today we have completed carcinoid, we have done Peutz-Jeghers syndrome, we have done everything about the appendix including appendicular mass, appendicular abscess. Okay, we have done the entire appendicitis. Then we have done volvulus, sigmoid as well as cecal. We have done intussusception, and we have done Meconium Ileus, and we have done Duodenal Atresia. Okay, so those are all the topics that we have done today, and the next class will be tomorrow at 11 o'clock. Now for the next 3 days we have class at 11 a.m, 11 to 12:30 a.m. Tomorrow we'll be doing large intestine, then we will be doing genitourinary system, and then the third I will decide what has to be done. Okay, so with that we will be done with a lot of our surgery revision, and from tomorrow I'm also starting a plus course on anesthesia revision for NEET PG. So that will be tomorrow 4 to 6 p.m. every day, 4 to 6 p.m. Okay, so 11 o'clock we'll have the free class on YouTube, and 4 o'clock we will have the plus class on the Unacademy platform. Okay. Okay, so thank you so much guys for joining me today. Please don't forget to like the video if you enjoyed it, and I will leave the links to all of these videos in the chat box in the Telegram ID, and I've also released a short 3-minute video which will be useful for you all for 3 effective revision techniques for your exam. Okay, so you can use those videos and start revising, because now we are getting closer to the exam. All right, thank you so much, and I shall see you next time. Till then, keep studying.